Welcome back, guys. Today we'll be discussing about gastrointestinal surgery. First topic we talk is pathogenesis of gallstones. Whenever the normal levels of cholesterol, bile salts, and phosphatidylcholine is disrupted, it forms a supersaturation of bile around the cholesterol. Remember, the normal levels of cholesterol, bile salts, and phosphatidylcholine will be essential for the maintenance of biliary micelles. Whenever there is biliary micelle formation, they will be remaining as a vesicle and they can be unsaturated with the cholesterol. Whenever there is increase in the cholesterol, whenever there is decrease in the bile salts, and whenever there is decrease in the phosphatidylcholine, the bile becomes supersaturated with the cholesterol. Whenever there is supersaturation of the cholesterol, it forms a debris or it forms a mass around the cholesterol being the center. Whenever there is an aggregation of all the calcium salts and the mucus associated with the gallbladder hypomotility, then there will be a formation of cholesterol stones. This is very important. Remember, on the CT scan, renal stones are easily picked up. On the ultrasound of the gallbladder, it is the biliary stones that are easily picked up. When we talk about the hyperbilirubinemia approach, you will first have to assess if it is a conjugated bilirubin that is elevated or if it is unconjugated bilirubin that is elevated. Because we discussed in our medical lectures, the gastrointestinal lectures about the bilirubin metabolism. Whenever bilirubin metabolism is happening, it is basically because of the RBCs that is hemolyzed and the heme, it is converted to biliverdin. The heme is converted to biliverdin by heme oxygenase. It is the biliverdin reductase that forms unconjugated bilirubin from biliverdin. Whenever there is unconjugated bilirubin, it enters the liver and then it is acted upon by glucuronide transferase and conjugated bilirubin is formed. This conjugated bilirubin enters into the gastrointestinal tract and is acted upon by the bacterial dehydrogenase. Whenever the conjugated bilirubin is acted upon by the bacterial dehydrogenase, it forms urobilinogen. This urobilinogen is converted to stercobilinogen and is excreted in the feces. Whenever you find a question of hyperbilirubinemia in USMLE, you will have to first think of is it an unconjugated bilirubin or the conjugated bilirubin that is raised. Whenever the unconjugated bilirubin is raised, it is the causes that is outside the liver. It is basically because of the hemolysis, which causes the overproduction of unconjugated bilirubin. It is basically because of the uptake that is reduced by the drugs or sometimes by the portosystemic shunts, and sometimes there can also be conjugation defect, that is Gilbert syndrome. In USMLE step 2, Gilbert syndrome is commonly asked because in Gilbert syndrome there will not be any elevation of liver enzymes. That's the most important thing you'll have to remember. Remember, after assessing the hyperbilirubinemia, whenever it is conjugated, you will have to then think of the liver enzymes. If the liver enzymes are elevated significantly, I want you to understand that viral hepatitis is one of the most important cause. It can also be related to autoimmune hepatitis. It can also be because of the ischemic hepatitis. It can also be because of the alcoholic hepatitis. So when you find unconjugated bilirubin that is elevated, you will have to first understand that the liver enzymes, is it normal or is it elevated? Remember, we have discussed a lot of clinical scenarios in clinical medicine when we are talking the evaluation of liver pattern enzymes. In the question, when you find that the conjugated bilirubin is elevated, next you'll have to look for liver enzymes. Whenever there is predominantly elevated liver enzymes, you will have to first think of viral hepatitis. I will tell you what are all the conditions where liver enzymes are elevated. Predominantly, it is viral hepatitis for USMLE step 2. Think of ischemic hepatitis, think of toxin related, think of autoimmune, think of alcohol hepatitis. In the question, there will be elevation of conjugated bilirubin with the patient history of travel and contamination of food products. It is the hepatitis A. IV drug abuser, it is the hepatitis B, that is the diagnosis. Whenever there is type 1 diabetes mellitus, it is the autoimmune hepatitis, that is the answer, where conjugated bilirubin with the elevation of the liver enzymes is basically seen. Remember, if the patient is admitted to the hospital and is in the ITU and has got a history of shock, it is the ischemic hepatitis that the patient usually presents with. Ischemic hepatitis, the AST and ALT are elevated in thousands. Alcoholic hepatitis, patients will have history of binge drinking as well. Remember, whenever there is conjugated bilirubin that is elevated, the next most important thing you have to look is liver enzyme pattern. Whenever there is a normal liver enzyme pattern with elevation of conjugated bilirubin, it is the Dubin-Johnson syndrome or the Rota syndrome that you will have to remember. If the bilirubin unconjugated, if the conjugated bilirubin is raised along with the elevation of ALP, you will have to think of cholestasis of pregnancy if the patient is pregnant. You'll have to think of pancreatic cancer, or you'll have to think of ampullary pancreatic cancer. You'll also have to think of cholangiocarcinoma if the patient has got pigmentation, weight loss, and is pruritic. You'll have to think of primary biliary cirrhosis in a patient who is female. You'll have to think of primary sclerosing cholangitis in a male who has got ulcerative colitis. Cholelocholithiasis can be seen in patients with fat female. You'll have to think of cholelocholithiasis with elevation of conjugated bilirubin and raised ALP pattern, please. The investigation of choice for predominantly elevated conjugated bilirubin and raised alkaline phosphate is abdominal imaging ultrasound, please. Very important. Next, we talk about biliary atresia. I remembered that biliary atresia is one of the most common cause of liver transplantation in children. That is how I remembered biliary atresia. Whenever there is biliary atresia, there is atresia of the biliary tract. So there will be extrahepatic bile duct fibrosis. Whenever there is extrahepatic bile duct fibrosis, it is the conjugated hyperbilirubinemia that is seen. It is the conjugated bilirubin that is elevated. Patients are usually asymptomatic at birth, and patients will be children for biliary atresia. It is the infants that are usually less than 10-week old. The patient develops jaundice and there is associated hepatomegaly, please. Whenever you do an ultrasound, it is basically a gallbladder atresia that you will find. So you will have to do a definitive diagnosis, that is by liver biopsy, where you will find intrahepatic bile duct proliferation. Remember that. And in the question, they will give you about the fibrosis, please. But the gold standard diagnosis is intraoperative cholangiography, where you can find biliary obstruction. The most common treatment is liver transplantation. Sometimes they Next, we talk about primary sclerosing cholangitis. Remember, patient with the primary sclerosing cholangitis, in the question, it is a male patient that usually has inflammatory bowel disease. Or if the patient has got asymptomatic, or if the patient has got fatigue, you'll have to think of primary sclerosing cholangitis, given the patient has got background history of ulcerative colitis, please. Whenever there is primary sclerosing cholangitis, you'll have to think of raised alkaline phosphatase with conjugated bilirubin that is elevated. Whenever you do a cholangiography, you will find multiple strictures and there will be dilation of the intrahepatic and extrahepatic bile ducts. Very important. Next, we talk about the liver biopsy findings, which is usually given in the question, where you will find fibrous obliteration, or there can be onion skin pattern on liver biopsy. Remember, in primary sclerosing cholangitis, it is the complications that the examiner is interested in. The complications of primary sclerosing cholangitis is cholangiocarcinoma in a female. Okay. So whenever you do laboratory tests in primary sclerosing cholangitis, it is basically the raised alkaline phosphatase with the elevation of conjugated bilirubin that you will find. But in the clinical scenario, it is classically a male patient associated with inflammatory bowel disease. You'll have to select. Whenever there is fatigue and pruritus in the question, you will have to think of primary sclerosing cholangitis. Remember, the biopsy findings in primary sclerosing cholangitis is onion skin pattern. In
Again,
cholangiography,
no voice.
so when you do a cholangiography, you will find there is a stricturing or there is a dilation of the intrahepatic and extrahepatic ducts in primary sclerosing cholangitis. Remember, the complications are usually asked. It is the osteoporosis, it is the patient presenting with fractures, it is the patient presenting with vitamin deficiencies, especially the fat soluble vitamin deficiencies, ADEK. Whenever there is a 50-year-old male female patient with weight loss, pruritus, and history of primary sclerosing cholangitis, you will have to think of cholangiocarcinoma as one of the most important diagnosis. Next, we talk about the colonoscopy indications for primary sclerosing cholangitis. Remember, whenever a patient is diagnosed to have primary sclerosing cholangitis, a colonoscopy must be performed whenever there is a new diagnosis of primary sclerosing cholangitis. Remember, the annual colonoscopies must be done when the patient has got primary sclerosing cholangitis and is also associated with inflammatory bowel disease because we are ruling out a colon cancer by screening these patients. Next, we talk about calculus cholecystitis. Whenever calculus cholecystitis or stones in the gallbladder are identified, if there are no symptoms, please do not do anything. If the patient has got cholecystitis, you will have to make sure that the secondary bacterial infections are first treated, and then you can do a cholecystectomy. Remember, whenever there is calculus cholecystitis in the question, the patient presents with abdominal pain. The patient is fat female in her 40s or 50s with high fat diet, usually have pain after a heavy meal or pain after a fatty meal. That is how you will have to diagnose cholecystitis. Whenever there is cystic duct obstruction that causes accumulation of debris and that causes bacterial infections. Whenever there is bacterial infection in the gallbladder, remember there are the complications that is most important for USMLE step 2. It is the gallbladder empyema, it is the pericholecystic abscess, and it is the sepsis that the examiner is interested to find you out. Remember, all these infections present with fever, but the pain will be prolonged in different conditions and the infection will also be prolonged in these complications. So remember, calculus cholecystitis, it is not identifying the disease, but it is about identifying the complications. You will have to treat them. Next, we talk about the treatment of cholecystitis in patients with infection. Whenever there is infection, you will have to make sure that piperacillin tazobactam must be given for patients with cholecystitis. And these piperacillin tazobactam are usually given to cover aerobic and anaerobic infections. Please remember, the most common infections we are treating is E. coli, Enterococcus, and Klebsiella as one of the most important organisms we are treating. Remember, if the patient If the patient has got high alcohol intake, it is the Klebsiella that you will have to think of, the organism that is causing acute cholecystitis. Remember, antibiotics are given until cholecystectomy is performed. Next, we talk about acalculous cholecystitis, which is usually a common question asked in USMLE Step 2. Whenever there is acalculous cholecystitis in the question, they will mention that the patient has got history where there is prolonged admission to the hospital, or there is sepsis, or there is a post-operative complications, or there is pancreatitis, trauma, ARDS, shock, anything, or the patient can be on total parenteral nutrition as well. These are the findings where acalculous cholecystitis can develop. Remember, acalculous cholecystitis, when it develops, it is basically developing in patients who are stressed out. That is, patient who has got recent hospital admission, patient who has got recent ITU admission, patient who is being treated for a total parenteral nutrition, patient who has a history of sepsis but is still admitted in hospital. That is when you will have to think of acalculous cholecystitis. Age does not count in acalculous cholecystitis, please. Whenever there is cholecystitis, it is the itis, it is the inflammation that is going on. So there will be unexplained fever because on the ultrasound there is no calculi in the cholecystitis in the gallbladder. That is what you'll have to think of. But the pain will be present. It is the right upper quadrant pain that you will have to think of. The patient can present with jaundice and the patient will be having an abnormal LFTs. Sometimes the patient can also be having normal LFTs, but still you'll have to think of acalculous cholecystitis when there is no pain, when there is no stone in the gallbladder. That is very important. The complications for acalculous cholecystitis is very rarely asked, but remember the most important complications for acalculous cholecystitis is gangrene. The next most important complication usually asked in the exam as a different question is emphysematous cholecystitis. Whenever there is acalculous cholecystitis, it is the antibiotics that we will need to give as an initial step in the management. Whenever the patient is not responding to antibiotics, it is the percutaneous cholecystostomy we will have to do. That is putting a drain. If the patient is not responding and if the patient has got hypotension, you will have to give percutaneous cholecystectomy. But if the patient is not responding to percutaneous cholecystectomy, if the patient has got cholecystitis, and if the patient is stable, then you can only do cholecystectomy, please. Very important. Whenever there is acalculous cholecystitis, the examiner would love to ask you the diagnosis. So usually the first step is doing an abdominal ultrasound. But HEDA scan is the most popular scan that we usually do for acalculous cholecystitis. It is basically called as hepatobiliary iminoacetate acid scan. That is what you will have to do, please. Next, we talk about the most important complication, most important cholecystitis, that is emphysematous cholecystitis. Emphysematous is nothing but there is air in the gallbladder. It is basically because of the E. coli and Clostridium that forms the gas in the gallbladder. So
Again, no sound.
whenever there is whenever there is air in the gallbladder, you will whenever there is air in the gallbladder, the patient will have right upper quadrant pain, and on the ultrasound there will be gas in the gallbladder. The complications of emphysematous cholecystitis is usually perforation. That is why you will have to identify emphysematous cholecystitis in order to prevent perforation. Whenever there is perforation, the pain is relieved, but there will be onset of peritoneal symptoms. There will be guarding, there will be rigidity, on clinical examination whenever the patient has got a rupture or perforation of cholecystitis. Remember, this is an infection and an inflammation that is going on. So, what did we learn? It is the CT scan that is the best investigation of choice where we can easily diagnose patients with emphysematous cholecystitis. In the CT scan, there will be a rim of air in emphysematous cholecystitis, please. The treatment for emphysematous cholecystitis, you will have to do an urgent cholecystectomy. Whenever you think of emphysematous cholecystitis, please do give IV antibiotics for Clostridium and E. coli. The antibiotic of choice is piperacillin and tazobactam. Examiner would love to confuse you with one of the differential diagnoses for emphysematous cholecystitis. It is basically the biliary enteric fistula. Whenever there is biliary enteric fistula, it could cause ulceration of the gastrointestinal tract because of the pressure from the stone in the gallbladder. So remember, whenever there is emphysematous cholecystitis, it is the biliary enteric fistula you will have to identify. But fistula, it is just a normal pathological process that is going on. So there will not be any fever or the patient will not be ill. That is, there will not be any sepsis or there will not be any fever in biliary enteric fistula. Next, we talk about estrogen induced gallstone. Whenever there is estrogen induced gallstone, the question points out towards a young female. The patient will be on estrogen. The patient can also be postmenopausal women. Very important. Remember, estrogen usually increases the cholesterol synthesis. That is how estrogen forms gallstones. Not only estrogen forms gallstones, but also progesterone can also help in the formation of gallstones. Progesterone decreases the bile acids and progesterone decreases the gallbladder emptying. Whenever this happens, there will be formation of gallstones. Remember, the two most important hormones that can
Sounds tough.
facilitate two most important hormones that can facilitate in the formation of gallstones is pregnancy, estrogen and progesterone. Remember, in the question, they can mention about pregnancy and also the oral contraceptive pill use. When we talk about the management of gallstones, whenever you find gallstones without any symptoms or whenever the patient has got an incidental finding of gallstones, there will not be any treatment. But when the patient has got symptoms with gallstones, that is pain, you'll have to do a elective cholecystectomy. That is very important. Sometimes the examiner can tell you that this patient is not fit for cholecystectomy. What would you do? You will have to give ursodeoxycholic acid in patients who are not fit for surgery. Remember, there can also be complicated gallstones where the patient can present with infection or acute cholecystitis, or patient can also have gallstones in the cystic duct, or patient can present with pancreatitis. When they present with complicated symptoms or disease, you will have to do cholecystectomy first, treating the infection or the cause. Remember, cholecystectomy after correcting the infection is the management of choice for treatment of complicated gallstones. I'll send you a new link and then we'll meet there. Thank you very much.